bed, I hear the clock ticking. Think of you, we're caught up in circles. Confusion is nothing new. Flashback to worn out, all those left behind. A suitcase of memories.
Now, focus more on decision making. There's a lot of the work that I do with adult protective services is decisional capacity assessments. And then we'll have like an hour lunch break, I believe, and then come back for drugs and alcohol. Drugs and alcohol. In this hour, we're going to talk about applying medical courts in legal settings, understanding legal standards, and how these capacity assessments are done. If there's only one thing that you walked away from this hour, it's going to be, there's only one thing to learn. The thing to learn is knowing that it is executive function that best predicts a person's ability to care for themselves independently. It's executive function that correlates the best with decision capacity. And then we'll talk about different ethical and sometimes ethical dilemmas that we encounter when we're doing these capacity assessments. This isn't a big disclosure, but it's an important disclosure to say, which is that I do a lot of work with adult protective services. There is a financial contract between adult protective services and the University of Texas Health Science Center in San Antonio. So I don't do these just because I'm a nice guy. I do them because it's actually the university that contracts me out to adult protective services to do these decision-making capacity assessments. So UT is fine there. Okay, so a lot of y'all know this, right? So this is how APS is carved up across the state. We sit in Region 8. If you're not with Adult Protective Services, you're not an APS member of the audience. APS is carved up into 11 different regions throughout the state. San Antonio sits in Region 8. It's about a 2.5, 3 hour drive from here to Port Lavaca on the coast. And another 2.5, 3 hour drive to Del Rio on the border. And so on Wednesdays, Adult Protective Services picks me up at the doorsteps of UT, and away we go into this 28-county region to stamp out decisional capacity. What fun, right? All right. So these are the questions that APS is wanting me to help them answer. So I do think what's important to know is that when I'm working with APS, I'm working in the role of the consultant, right? So APS is asking me for my thoughts and my opinions based on the medical training that I have. They're not asking me to tell them what to do, right? APS is a whole bunch of smart people. They don't need anyone telling them what to do. They're just wanting to use my evaluation to help inform them, to help inform how they serve the clients that they have. So the first question they want to know is, does this APS client have a psychiatric diagnosis, right? So often the APS field workers will say, I know there's something wrong, but I don't know what it is. And can you help me? Is this psychiatry or what is going on here? I think they might have dementia. I know that they drink alcohol. Do they have a psychiatry diagnosis? They want to know if the client has decision-making capacity as defined by Texas law, not as defined by what seems like decision-making capacity ought to be, right? They want to know, do they meet the legal definition for decisional incapacity? APS wants to know what level of care their client might need. Do they need assisted living level of care, a nursing home level of care? Are provider services sufficient? Do they need any care at all, in fact? So APS wants to know that. And then the last thing is the situation so bad that the client needs to be emergently removed? Does this client need to be extracted from their home today against their will, cleared in an emergency medicine setting, placed in a nursing home setting until the judicial system sorts out the need for guardianship? So does there essentially need to be a rescue mission, if you will, for this client? So we always start with the legal definition of capacity. And so every state has a law that defines capacity. And in Texas, this is the law, right? This isn't my opinion of what capacity means. This is just the law. So in Texas, an incapacitated person is an adult who, because of a physical or mental condition, is substantially unable to provide food, clothing, or shelter for himself or herself, to care for the individual's own physical health, or to manage their own financial affairs. And you might like that definition, you might not like that definition. Your opinion of the definition doesn't matter. My opinion of the definition doesn't matter. This is Texas law, and if I have to go to court and testify that a person does or doesn't have capacity, this is the definition that I'm testifying that they meet or don't meet. And so I always tell APS workers that if you're going to ask a physician to do a capacity assessment, you have to give them a copy of it, because they don't. Physicians do not know that there is actually a legal definition for capacity. They just don't know that. Most physicians have an idea in their head of what they think capacity is, and they'll give you an opinion based on the idea in their head, but it may not be what you really need. So I always recommend to APS, if you're going to ask a person's primary care doc for a capacity assessment, give them a copy of the law. I also tell people that the most important words in this definition are the verbs, not the nouns. Okay, so is the person providing food? It's not do they have food. It's not do they have clothing. It's are they able to provide, and it's implied in the law, safe. Are they able to provide safe food, safe clothing, and safe shelter, right? So, so the key word in definition is verbs. Just like it's not do they have medical problems, right? It's are they able to care for their own physical health. It's not do they have money. It's are they managing money. So there's a difference between having and managing, right? So again, when we do these assessments, Adult Protective Services, in almost every case, has established that the person, that their client has a disability. They've established that the person is either not managing their money, or they're not caring for their health care, or they're not providing a safe shelter. They've established the disability component. And then as the physician, my job is to decide, are they not doing these self-care activities because of a physical or mental condition, or are they not doing them just because they're choosing not to do that, right? So, this is America. You're allowed to live in a house that's a complete mess, right? That's your right. But you're not allowed to do that, as it turns out. You're less allowed to do that if you're doing it because you're incapacitated, okay? So as long as you still have the ability to evidence choice, and cognitive structure to think reasonably, then you can do that. But once you lose that, then your rights start to become threatened. So APS will pick me up, and away we'll go, and tell me the story, and we're trying to sort out who they meet this definition. So then, just kind of ethical, legal, different clinical issues to think about first. So who can do capacity assessments? So what type of doctor? Medical doctor. Any kind of doctor, right? So any MD, medical doctor, DO, osteopathic physician, any type of medical doctor can do it. You don't have to be a psychiatrist, right? A radiologist could do this, or a pathologist, or an endocrinologist, a pediatrician. It doesn't matter. So physicians definitely. Who else? Yeah. Licensed clinical social workers can do these as well. That's right. Who else? Nurse practitioners. Advanced nurse practitioners. That's right.
Psych nurses.
And then RNs can't. I don't think RNs can. I think you have to have a nurse practitioner. You have to be an advanced nurse practitioner. There's one more. Clinically licensed psychologist, specifically neuropsychologist. So clinically licensed neuropsychologist. So there's 4 groups of people that can do these assessments. However, if the case is going to go to court for guardianship, a physician has to be the one to sign the certificate of medical exam. So although there's 4 groups that can do them, if it's for the case to go to guardianship, they have to have a physician assess. So the other types of providers are great, particularly in emergency situations, right? There's something dire that's going on, we've got to rescue this person. But then once the fire is put out and the elder is safe, then a physician has to step in, do the assessment as mandated by state law. This is state law. Okay, so that's going to the right. So let me ask you, when should Adult Protective Services tell the client that I'm coming, that I'm on the way?
Yeah.
Some say no. Some say yes. Why do you say yes? Why shouldn't they be told? Okay. All right. Some say no. Why no? Yeah, so a lot of times, the audience will kind of have mixed opinions of this. I can tell you, I don't think there's a right or wrong answer, and I always defer to Adult Protective Services because they know their clients best, and APS knows that there are some clients if they say, Mr. Jones, I'm really concerned about you, and I'd like to bring a doctor here to talk with you and figure out if there's something that needs to be done. Then what they might know is that Mr. Jones he'll wake up early that morning. He'll put on his tie and he'll be there to greet me when they ring the bell. But Adult Protective Services also knows that there's some of their clients that will be out of there. Right, and so I always defer to APS, and I think a lot of this is also these assessments are expensive. So I told you at the beginning that the assessments that there is a contract between APS and UT. The contract is $300 an hour. I don't know if y'all know that or not, but it's $300 an hour is what Adult Protective Services contracts for. When we do the in-county assessments, what that means is that each in-county assessment costs about $600. It's 2 hours. By the time, we go to the person's house, we do the interview, by the time I write the report, it takes about 2 hours is what it takes to do it in town. But you can imagine for out-of-town assessments, if we're going to Del Rio, for example, I can tell you, I went to Victoria last week, it's 2.5 hours there, 2.5 hours back, that's 5 hours total, that's $1,500, and we haven't even seen the client. It's $1,500 in travel time, right? So you can imagine that that if APS, Sarah Polsowski in Victoria, if she has any concern that the client's been involved, then she's not going to tell the client because, how often do I get out to Victoria, plus just all the money that could be washed, essentially for nothing, right? So when it comes to should the client be notified if I'm coming or not, I really do defer to Adult Protective Services judge as to what would be best. Should the client be informed about the purpose of the evaluation? You say yes? Some say no. So should just kind of knock on the door? Hi, I'm just here to. We were in the neighborhood, and saw your yard was, right. So So I think the client should be informed. And in fact, when you do assessments, you know, we never pretend that this is something other than what it is, right? And so, you know, if you've ever been in the field with me, there's this whole disclosure that I always give them up front. I clearly identify myself as being a physician. I clearly say, you know, that, you know, kind of describe the relationship that I have with APS, right? I always say, you know, I don't work for APS. APS doesn't work for me. We work together. There's this whole disclosure that we have. And I always tell them that, you know, when Adult Protective Services has medical questions about their clients, they ask me to come help answer those questions. And it's particularly when they have questions related to their clients' memories, problem-solving abilities, decision-making abilities, right? That's what I'm telling the client. And so they know what this is about. Oh, yeah, absolutely they have the right. The question was, do they have the right to decline? Without a doubt. Yeah, they have the right to decline. They have the, if they don't give us permission to enter their home, then we never go into the home without their permission. Absolutely. So if I give this disclosure and they say, thanks but no thanks, then we're done, right? Adult Protective Services can pursue a court-ordered evaluation. So then they can say, look, we tried to do this least restrictive, we brought Dr. Schillerstrom out, the client refused, we're really concerned about the client, we have to get this done. And if the judge agrees, then they can court order an evaluation. But initially, if the client declines, absolutely, we don't. We might encourage, in fact we do encourage them to participate, but ultimately if they say no,
That would be wasted.
what's that?
That would be wasted.
Yeah, that's right. Yeah, then it's for nothing. I mean, that's exactly right. Yeah.
Might be better shut down.
This is kind of interesting, but from what I know of Adult Protective Services during the initial visit to the home, no one is given advance notice. So, in my opinion, if you were to accompany Adult Protective Services on an initial visit,
Yeah.
then it's my understanding that no one has to announce your presence. But during the home visit,
Yeah.
if I were the APS worker, I would say Dr. Schillerstrom is here to assist me in assessment,
Yeah.
and yada, 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 yada.
Yeah.
But on a
very-
second visit,
Uh-huh.
I think professional courtesy would dictate that, yes, I would tell the client, well, I'm coming back out to you, and this time I want to be accompanied by, with the legitimate purpose of.
Right. And so they do that, but we do have to defer. I mean, I do defer, because they're really dangerous situations where not only is the client's health threatened, but the people living next door is as well. I mean, there really are bad situations. And I can also tell you this, that it is rare. I mean, it would be less than one a year. We've been doing this since 2008. It's rare that I'm going with APS before they've seen the patient. Most commonly, I'm going out with APS after they've been working with the client, usually for what, like 2 or 3 months, usually, about 3 months, right? So they really, in almost every case, Adult Protective Services has established a professional rapport with the client. And in fact, in almost every case, it's that trust that the client has with the Adult Protective Services person that that initially facilitates the whole interview process. So,
I think I'm safe to say this because I do work with Geriatric services, and there have been some situations where there's implied extremely, locked up in a 140-degree house with dead carcasses on the floor. You don't have the 2 or 3 months to establish that relationship. You got to get somebody in there and get them to do that.
yeah.
So does that person still have the right to say no?
Yeah. Yes. The answer is yes. Yes. Yeah. So yeah. I mean, we've been in houses with dead animals and flashbacks. I'm having PTSD. The answer is right. So if Adult Protective Services goes out there and thinks, "Oh dear God," then the next visit I might be out there helping them when they've only been with that client for the initial encounter. So that happens, but still, the client can refuse, and if the client refuses, they don't let us into their house. We cannot go into their house. If a lot of times they'll say, "Well, you know what? I don't need to go into your house," and the truth is, I don't need to go into their house at all to do the assessment. And the truth is, a lot of times I don't want to go in there. A lot of times they say, "Come on in, Doc." I'm thinking, "Oh dear God, no." And so, oh, just look out here on the porch, right? I love the porch. There's nothing I like better than a covered porch. So yeah. I mean, it's. So the client is informed about my evaluation, and not only are they informed about my evaluation, but they are informed that this evaluation is not confidential. And in fact, if I don't tell them before the assessment that what they tell me isn't going to be confidential, then the assessment is invalid. It does not hold up in court. In the certificate of medical exam, I specifically have to check the box that says whether or not the client was informed that the assessment wouldn't be confidential. If I don't check that box, yes, then the assessment's out. And so I tell them, again, in the whole disclosure, I'm telling them that, normally when you talk with a doctor, it's private. Normally what you would tell me is only would be between us. It wouldn't be anybody else's business. But today, that's not true. Today, the report will go to Adult Protective Services, which is a state agency. I tell them. And I tell them, so if I ask you something and you don't want to talk about it, you don't have to. I tell them, right? You don't have to. And I tell them, I won't get angry at you. You won't hurt my feelings. We'll just move on, right? And of course, the most common reply is, what? Doc, you can ask me anything. I'm an open book, right? And that's when I know, oh God, they don't have capacity. Right? Anybody went knocked on your door, right? If any strange person knocked on your door, they gave you the disclosure that I'm giving the client, in your capacitated mind, you would say, so what you're saying is that, right? Is that you're going to evaluate my memory and problem solving and decision making abilities, and you're telling me that nothing we say is going to be confidential? Yeah, I don't think, and I don't have to do this. All right, well then we're not going to do it, right? I mean, that's what any life says, right? That's what it says. So how many cases? So for the non-APS, so don't answer this if you want to make a guess. So how many cases per? How many calls per year does Texas Adult Protective Services get? Take a guess.
Per day or per what?
Per year. How many?
Per year?
How many contacts per year does Texas Adult Protective Services?
In Bexar County only?
No, across the state.
73.
Yeah, so in fiscal year 2012, they had 108,000 cases, right? They got 108,000 calls, right? So if you divide that up among the different, if you assume kind of an equal distribution, which isn't true, but if you assumed it, that means is that Region 8 is getting about, what would that be, like 10 or 12,000, 10 to 12,000 cases is about what Region 8 would get. I do probably now about, because before this year I was doing about 100 cases per year. And so I'm only seeing 1% of all the clients that so by the time a client kind of gets to me, right, I should be going, by the time a client gets to me, I mean, Adult Protective Services has tried every avenue to assist the client without a capacity assessment. So I really am seeing a very small fraction of the greater body of work that APS sees. So there's a lot of, the reason I say that is there's a lot of selection bias by the time the case. I don't see the average APS case. I see the ones where where their least restrictive interventions just weren't safe. Okay, and then we've kind of talked about the finance and that kind of thing. I always say, well, does the contract? So there is a financial contract. Does that contract bias my opinion? So again, I don't get paid directly by APS. I'm salaried through UT. I get paid the same salary whether I do this or not. What I also say is that if it does bias my opinion, it doesn't bias it in a way that is necessarily good for adult protective services. Right? So, are most of the clients that I see, do most of them have capacity or don't have capacity? Like 97% of them do not have capacity, right? So adult protective services doesn't, by the time they're thinking, so I see ones that don't. But when you think about the workload for adult protective services, is it better for them if the client has capacity or doesn't have capacity? It's better for them if the client has capacity, right? Because if the client has capacity, they sign off and they're done, and they can move on to their 108,000 other cases, right? If I say the client doesn't have capacity, then I always feel bad because he goes, because that means the work's about to begin, right? I mean, that means like, and not only is it, but the real heartbreaker is, do we have to remove him? And if it's, yeah, oh, right. So if the outcomes of these assessments do bias me, I can tell you it doesn't help out with APS workload. That's what if the client's Spanish speaking only? Should I see those cases?
Yes.
Huh? An interpreter? Some say yes. Anyone say no? I don't speak any Spanish. I mean, what does the Spanish I speak? I don't speak. The only Spanish word I know is no. Because it's the same. So what if the client's Spanish speaking?
No.
With an interpreter? Yeah, I can tell you. This is without a doubt. Ethically, this is the challenge that I personally struggle with. And so, given the potential outcomes of these cases, I truly believe that these assessments need to be conducted in the client's language of preference by an examiner who really speaks that language, given the potential outcomes. On the other hand, what I know is that, if there's a Spanish-speaking only client in Cuero, for example, there's not another board-certified geriatric psychiatrist who's fluent in Spanish who's going to go out there with APS, right? We just don't exist, right? And so then if that client isn't seen, then a lot of harm can come their way. And so I'm always really asking Sonia samples, are you sure there's no one else that can do it? Right? And so and then she's scrambling to see if she can find someone. But so that's where I'm stuck, right? And, on one hand, the client's rights really need to be respected given the potential outcomes. On the other hand, there may not be anyone else to do it. And so that's where those are my thoughts on that.
And so, do you take an interpreter, or do you just use a translator?
So sometimes adult protective services will provide the interpreter. Yeah. And then sometimes what I'm also okay with is within our trainees. So we'll have geriatric psychiatry fellows or residents, upper level residents, someone with a medical background who is Spanish speaking. And I'm very comfortable using them as an interpreter because not only can they interpret, but when we're doing the neuropsych testing, they can really they have in fact already translated all of that. So that's why I tried it later on. Let's see here. So who should be doing these assessments? Me, someone that the client doesn't know, or the client's primary care doctor?
You.
Me. Maybe the primary care doctor should do it first.
How often do they actually have a primary care doctor?
We've already tried that by the time we get to you.
Yeah, and so often what happens, right, that's exactly right. Often what happens is that APS has tried to have the primary care doctor put forth a statement, and either the primary care, one of two things happened. Either the primary care doctor said, I don't want to do it. Well, one of three things happened. The primary care doctor doesn't respond at all to APS, is one thing that happens. The other thing that happens is that they say, I don't want to do that. Or the third thing that happens is they say, yeah, okay, I'll write a statement. And then APS gets the statement, and there's inconsistencies perhaps within the document, something like that. And so what I know is that Adult Protective Services as an organization would love it if the primary care doctor would do this, because if they did and they did it well, then then they wouldn't have to pay UT for me to do it, right? And so that's what I know. On the other hand, primary care doctors hate doing this. They hate it. How come?
Time consuming.
What?
It's a liability.
A liability in what way?
Well, if they say the person does have capacity and something happens to the person because they didn't completely assess or they missed something, then they have a responsibility to the care of their patient.
Yeah.
Or if they say they don't have capacity and they end up in a courtroom and they saw the patient for 15 minutes in their, exam, then they may not be able to testify to the point that they're being asked.
Right, so there's an inherent conflict of interest. So if the client does not have capacity and the physician is honest, physicians are by and large very honest. If the physician says that the client does not have capacity and the case goes to court, then the line of questions goes like this. So when they're asking the physician, the line of questions goes, so does this client have capacity? No. Do they have capacity to manage their health care? The physician might say no. And then the follow-up question is well, have you been treating this client? Yes. Has the client been coming to appointments by themselves? Yes. Okay, so doctor, what you're telling me is that you've been doing medical services on a patient that you know does not have capacity to consent to the services that you're providing. Yeah. Right? Where really the physician is just trying to help out the person, right? You know what I'm saying? And so there is an inherent conflict of interest that they don't
The
want.
first thing that the supervisors tell you to do is call the doctor and ask the doctor.
Yeah.
And that is a huge waste of time because there's no doctor in the world that's going to tell you that, the APS worker that, over the phone.
Well, that can happen. What are other reasons that primary care doctors don't like to do this?
It's time consuming
What?
and too much
They're not trained to
paperwork.
do it. Right, so how many hours of continuing medical education does your typical primary care doctor get in decisional capacity assessments? None, right? All of their training goes into managing blood pressure or chest pain or whatever, infection, right? They don't get continuing medical education and capacity assessments. The training that they have is also very different. It's based on the medical model, right? So in the medical model of capacity, not the legal model, but in the medical model, when you're doing a capacity assessment medically, it's always for a specific thing. Does this person have the capacity to refuse dialysis, for example? Or do they have the capacity to refuse chemotherapy? And so in this model, the patient has to have been informed. They have to be able to voice a decision. They have to be able to voice understanding of the risks, benefits, and alternatives to what it is that they're consenting to or declining. And they have to be able to give a logical reason for the choice that they're making, right? So those are the steps that they have to say, look, I'm refusing dialysis because I understand the risks of refusing dialysis are that no, I have a serious kidney condition, my kidneys aren't working, I know that toxins will build up, I know the risk is that I could die from those toxins building up. However, look, I'm 85 years old, the dialysis causes me a lot of pain, and I can't tolerate that pain anymore, and I don't want to have this therapy. And then it would work out. What APS is asking is very different, though, from the medical model. They're not asking about something specific. They essentially want to know, can the client live alone? So how do you voice the risks, benefits, and alternatives to living alone, right? If you kind of touch
I was just going to say that, when I ask a physician for a capacity statement, I always get the same thing back. Client was alert and oriented during our last visit.
Because that's all they looked at. They didn't even look at it. I mean, that's exactly right. They were alert and oriented. So, they can walk and they can talk. So can my 3-year-old son. Right? So let's see here. So other reasons are that primary care doctors don't get paid to do these. You can only bill Medicare or other third-party insurance providers for providing a medical service. You can't bill Medicare for a forensic service, right? So it's going to be an uncompensated thing that they're going to have to do. They hate going to court. If they go, first they just hate lawyers in general, but then if they go to court, they have to close down their practice for half a day. So not only are they not going to get paid for it, but they're going to lose half a day of income for having to go to court. The assessments, we've talked about this, are different from the medical model. And then again, and really most importantly, is that, physicians who go into primary care go in because of the doctor-patient relationship. And they may have been working with this client for the last 20 years, and they just don't want to fracture that relationship, right? Because as soon as you say you're going to do a capacity assessment, it can feel, rightly or wrongly, it can feel like you're no longer working with your patient. You can feel like you're now working against them. And they just don't want to do that. And they'd rather defer that assessment. So these are all the reasons why primary care doctors just do not like doing capacity assessments. And APS needs them, then they contract out a third party, such as myself or another provider. So just to kind of walk through how these assessments are done. So we'll kind of take it as a case example. So let's see here. So this is one case. A 77-year-old woman was referred by APS. As we're driving along the car, APS is telling me all about the case. And the home is filled with garbage. It smells like feces in there. No electricity, no water, no phone. Patient's not getting medical care. There's some issue with Medicaid or Medicare. The client can't figure out what happened, but the end result is that she hasn't had any medical care at all in the last 10 years, probably. APS also says that the client's sisters are very concerned about her and want the client to move out of the house. So the sisters, are grateful for adult protective services interventions and don't think that this is safe. Adult Protective Services knows that she had been diagnosed with dementia sometime before by a primary care doctor. They know she has asthma. APS tells me that the patient isn't taking any medications. They know that she was raised in San Antonio, never married, no children. She's a retired salesperson, high school diploma. They're not concerned about substance use, no substance use that they know about. And so then when we show up to the house, this is what the outside of the house looks like. Right? So this is a case on the west side. So we show up, pull up to the curb, and this is the home, right? And so, and so if you go into the home, this is what you see, right? So if you go into the home, you just see piles and piles of garbage. Just piles and piles of garbage, right? So, given all of this, what do you do? What's that?
It doesn't take a psychiatrist.
Doesn't take a psychiatrist. No, it takes like someone with a much more practical skill set. So, right, so what would we do? What's the first?
I think for me personally, one of the first things that I would do is pursue the primary care physician's diagnosis of dementia.
Mm-hmm.
To find out how long ago was that.
Yeah.
And that would be the first thing that I would do.
Yeah, and the way we're going to really do that, I think what we have to do is we have to talk to the client. Right? That's what we have to talk to first to see what their understanding is, right? So, on the porch. So the first thing we're going to do is say, ma'am, can we talk outside? I see you have a covered porch. All right, so.
Did you see that porch? You're really going to
Well,
stay
we're not going to be on the porch. We're going to be out. We're not going to be right.
Yeah, I'll just stand.
The porch is bad, right? So, yeah, there's like all these like urinals. No, we're going to be like over here in the grass. Maybe underneath the shade. So, I didn't mention, yeah, these bottles aren't, there is a urine, in all those bottles that are there. And that's a water pipe that we rushed it through so she doesn't have water going into her home. It shows the big right, so we're going to talk to the client first. We always talk to the client first. And just see what she has to say. And so she says that she hadn't had medical care, this Medicare thing. She can't really explain it either, but what she knows is that she doesn't have medical care, or hasn't had it. She says, yeah, her house is messy. She'd like it to be clean. But the reason she hasn't cleaned it is because she can't find these savings bonds. She misplaced some savings bonds, and she doesn't want anyone to throw anything away because they might throw out the savings bonds, and that's why things look like this. She says that her home's messy, but she doesn't really see any health or safety problems. I always ask her, I say, is there anything others might think is unhealthy or unsafe about your home? No. Let's see here. She says that she has no water. She says she has electricity, but there's no one more clever than an APS person. So they take me over to the side of the house, they show me the meter, and they say, look, that's not sped. She doesn't have electricity. So she doesn't have electricity. Adult protective service done their homework. And then, when I always ask the clients, is there anything that adult protective services can do? Are there any services you need that might help? And this client said, there's this tree in my yard. It's like way over here on the side of the house. Way over there, there's a tree on the left side of the house. If adult protective services could get that tree out of my yard, I'd be really grateful. Right, so she's concerned about the tree, right? Okay. And then we just kind of look at her. And so when you look at her, she's thin, she's frail, she's thin woman. Her clothes are just covered in filth. Smells like feces. She's got like feces on the palms of her hands. In fact, I'm always it's the media. Okay. Thank God, thank you very much for bringing sanitizer. She's not depressed. Her thought processes are certainly illogical, but she's not psychotic. She's not delusional. She's not psychotic. Poor insight, poor judgment, but not, no real thought disorder other than her illogical thought, poor insight, poor judgment. And so, what I want you to appreciate is that this lady is, she's not obviously cognitively impaired. She's highly alert, and she is highly verbal, right? And in Western culture, if you are highly alert and highly verbal, then you have capacity. And that's a Western cultural thing, right? I mean, this goes back millennia. This goes back to the Greeks, right? This goes back to Socrates, right? So, in 400 BC, someone would say, hey, Socrates, does he have capacity? Socrates would say, well, he's awake and he can talk, so yeah, right? But we have 2,400 years of neuropsychology to inform us that there's more to having capacity than just being awake and being able to talk. Nonetheless, I do think it's important to know that, within our culture, if you're highly alert and highly verbal, the default is that you have capacity. which she certainly is highly alert about. The other question is, well, how much risk is society willing to tolerate, right? So, so what if her home's messy? So what if she, is dirt, right? So how much risk is society willing to tolerate? Whose job is it to decide? Is it my job to decide how much risk society is willing to tolerate? Is it Adult Protective Services' job? Is it Adult Protective Services' job to say, you know what, these living conditions are completely unacceptable? Is it their job?
No, that might be her lifestyle. But what I would be concerned about is how much of a risk does that pose to her neighbor?
Whose job is it to decide that?
It's the
Is
state's.
it the neighbor's job to decide how much they're willing to tolerate?
I
neighbor has like
wouldn't say
8
that's
cats. It's the judge's job. So the person whose job it is to decide how much risk society is willing to tolerate is actually the judge. That is their job. It's not my job. It's not APS's job. It's the judge's job. And I can tell you, in the 28 counties that I, stumble across, different communities are willing to tolerate different amounts of risk. And I see, decisions that I might think don't really make sense, but ultimately it's not up to me, right? It's up to the judge. And the truth is that if any given society doesn't like the judgment of the judge, well, then they can elect a new judge, right? So if the citizens of Bernie, for example, if a judge decides that it's okay for a demented elder to continue to drive, if the citizens of Bernie don't like demented elders driving through school zones, well, then they can just elect a new judge. And that's how America works, right? At least it's how Texas works, at least, where we elect our judges. Our judges aren't appointed there. So, okay. Were you scared? Were you nervous?
Yes. I was about to run out of here and just leave you guys on your own. Dish you guys.
That's awesome. So again, it's up to the judge to decide this. And then my job as the physician is to give the judge as much information as I can medically to inform their decision. And so I think what's important to know is when we're doing these assessments and when we're going to court, I do think that the medical piece of this is important. But I'm not so narcissistic as to think that the medical piece is the be-all, end-all, right? And so it's the judge's job to, take my medical testimony and then integrate it with Adult Protective Services findings, to integrate it with the life history of the client, the expectations within the community, other social structures, and to decide ultimately, how much risk society is going to tolerate, right? And so the medical piece, again, I do think it's important, but it's certainly not the only consideration, right? Okay.
Were you at odds with the initial primary care doctor who said that there was some dementia?
No.
Or not?
No. And we'll get to the case. The lady does have dementia. Yeah. We'll talk. So these are different. And then lastly, again, this lady's memory, when you're talking with her memory seems fine. And again, in Western culture, if their memory seems fine, they must have capacity. Because their memory seems fine. We'll talk about why that can be missed. Okay, so I've gotten collateral information from Adult Protective Services. I've now talked with the client. And so the way we proceed next is we might think about doing some cognitive testing or some functional testing, right? Okay. So again, in Adult Protective, in the definition of incapacity, a person has to be functionally impaired. They have to be substantially unable to provide food, clothing, or shelter, manage their finances, or care for their physical health needs, right? They have to be functionally impaired. So how do we measure? So how do you measure? How can we measure functional status? How can we determine if she's functionally impaired?
She's not managing her finances.
So how would you find that out?
Well, she's not.
So you'd ask, who would you ask? Her. Ma'am, can you manage your money? Yes, I can. Ma'am, can you drive? Oh, and her family. Okay, well, we'll talk about both of those. We'll talk about both of those. Because you're right. These are ways that you can do it. So one is self-report, right? So what is the problem with self-reported functional status? They tend to over-report their bills. If you look at epidemiological cohorts, they will tend to over-report their bills.
Are you doing this assessment on the board?
Yeah. Well, in the grass. Front yard. A little bit in the street. Yeah, we're not Skyping. Okay, so what's the problem with proxy reports, with asking the sisters, for example? What could be the problem? Denial, right? So it could be denial.
Or they want them, or they don't see it.
Or they want them to be in capacity. Yeah, so the bigger problem in epidemiological cohorts is that they over-report the disability. So you'll get statements like, my sister can't do anything. I gotta do everything, right? So caregiver burden can influence the report. When in fact there may be things that the client has to do. Of course, in adult protective services, where there's a special problem with proxy reports, right? And it's with exploitation, right? And so it's, can your dad manage his money? Oh yeah, he can manage his money. He knew exactly what he was doing when he wrote me that check for $50,000, right? So there's a lot of, okay, so self-reports, there's problems. Proxy reports, there's problems. What we do is a performance-based functional assessment. So what we do is we actually challenge the patient with functional tasks. I have them demonstrate to me how to read a bill, how to write a check, how to use a check register. I have them demonstrate to me how to use a phone book, that kind of thing. So we do a performance-based. The problem with performance-based functional assessments is that you're only measuring what a person can do when they're told to do it. You're not measuring what they really do, right? So, you could ask this lady, ma'am, if you were going to clean your house, how would you do that? Well, first, I would pick up all the clothes and I would put them in the laundry room. Then I would go through all the newspapers and I would recycle the newspapers. And then I would do this, and then I would do that. But obviously she's not doing it, right? So the only real way to really gauge functional status is to live with the person for a week and just follow them around and see what they do. But that's not practical. So that's how we do the functional assessments. That's the best that we can do. That's the best proxy. The other things that we will do cognitive testing. So we want to know what cognitions are essential to functional status. There's a lot of different cognitions. There's memory, there's executive function, there's math. Maybe you need to be on your math, processing speed, language. But the cognition, without a doubt, that consistently best predicts decision-making capacity or self-care abilities is executive function. And we've talked about executive function. It's that set of cognitive processes that's analogous to your problem-solving ability. And again, when people become executively impaired, they become dependent on habits and routines. So a common thing I'll hear is, a person might be living in squalor and filth, and a common thing I'll hear is, well, they've lived this way all their life. This is just how they are, right? Single man, whatever. And so my response to that is always this, is that, what we have to decide, is he living that way because he independently chooses to live that way, or has he lost capacity and now he's living this way because he cannot live any other way? He's living this way because it's now his habits and his routines that are forcing him to live like this. And even if he decided, I'm sick of the mess, he couldn't live any other way because he can no longer problem solve out of that, right? And that's the challenge that we have is, are they living this way by choice, or are they living this way out of habit? And that's what we're trying to distinguish. So there's different cognitive tests that we'll do to see if someone has that will start to probe for executive functioning. And so within this kind of matrix of tests, what all of these tests are doing is they're forcing people to break habits, right? So the way we test executive function is we force you to break your habits, okay? So, for example, audience participation part, thinking, oh, dear God, I just want to go to lunch. Please don't pick. Are you ready? I'm gonna executively test you. Are you ready? You're fired up. Are you ready? I'm going to say some numbers and letters like this. 1A, 2B, 3, what we pronounce. Perfect. Very good. Now, I want you to do the same. And I want you to start with the number 1 and just keep going until I say so.
1A, 2B, 3C, 4D, 5.
Good. Stop. That was good. That was perfect. Right, that was the best that's ever been done. Right, that was great. So how old were you when you learned to count to 10? Probably certainly before you could even. Between 2.5 and 3.5 is when you learn to count to 10. That's when most children learn to count to 10. Between 2.5 and 3.5, right? Somewhere in that range, they learn to count to 10. So counting to 10 is a habit. You learn to count to 10 before you even know what it means to be a number, right? And so that's why you can take, you can have a 3-year-old and you can say count to 10, and they'll go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. But if you throw 7 marbles on a table and you say how many are there, they'll do one of two things. They'll either say, I don't know, or they'll say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, right? And so it's a habit. The same is true with the alphabet. You learn the alphabet before you even know what it means to be a letter, right? And that's why children kind of blur letters to kind of form words. You might say like Alamo P becomes a word and not L-M-N-O-E, right? And so what I'm forcing you to do is to break the habit, to go from one habit, to break one habit after another and to alternate that. And so this is a test of executive function. It's not a test of language. It's not about knowing the alphabet. It's not a test of math. It's not about knowing number sequencing, but it becomes executive because habits are being broken. Another thing we'll do, probably the best predictor, in fact, is we'll have them say 8 words. So I'll say, okay, I'm going to give you a minute. I want you to name as many different things as you can think of that start with a letter. If I say P, you can say people, place, pot, plant, whatever comes to mind. And then I'll say, and the letter is always A. I'll say, okay, the letter is A, go. And I just see how many words can they get that start with the letter A. If they get more than 10, they're good. Less than 10, it's probably trouble, right? And so that's an example of, we don't sit around thinking of words that start with the letter A. That's not a habit, unless you have like obsessive compulsive disorder. But then you have a whole another problem. So that's an example. Here's another example. So can you tell me your name? Diane? Wait, Diane, so here's what I want you to do. Okay, so what I want you to do, Diane, let me see here, is I want you to tell me the colors. I'm driving Mark crazy. Mark's like, I'm trying to film, he's so far away. So I just want you to start here. I just want you to tell me the colors. So you'll go this way, and then you'll come down here, and you'll tell me, and you'll go this way, and then you'll stop after this box right here. And I want you to go as quickly and accurately as you can. Okay, are you ready? And I'm timing you. There's a second. Ready? Good.
Green, red, blue, red, blue, green.
Oh, perfect. That's excellent. Very good. All right. Now I want you to do the same thing, but this time I want you to read the words. And again, you're going to start here as quickly and accurately as you can, and stop when you get to this word here. And again, I'm timing you. Okay. All right. Are you ready? Okay. Are you ready? ready? Go.
Red, blue, green, red, blue, green, blue, red.
Perfect. That was perfect. Very good. Very good. Now what I want you to do is I want you to read. I want you to not read. I want you to tell me the color of the letters. So here you wouldn't say red. Here you would say green. So I just want you to tell me the color of the letters as quickly, accurately as you can. Are you ready? Go.
Green, red, blue, green, red, blue, red, green, red, green.
Wow, good.
That's really good. That's good. But you were slower. Did you feel yourself being slower? Did you feel your brain hurting a little bit? It hurts, right? So again, the habit, we're all verbal creatures. That's our habit. We're verbal creatures, right? So we see the word, we want to say green, say green, 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 green. But there's a part of your brain that says, hang on, you're not supposed to say green, you're supposed to say blue. Those letters are blue, right? And so the part of your brain that allows you, in fact, to do this task is, Diane, is that right? You don't ever want to play poker with Diane. Because the part of your brain that allows you to do this task is actually the part of your brain that also allows you to keep your poker face, right? And so it's the same part of your brain that's being probed here is, so if you're on 410 and you get pulled over for doing 70 and a 65, say, there's a part of you in which your amygdala that wants to say, damn it, I'm only going 5 miles over at 70. I was passing a semi. I've been passed by 10 people going much faster than me. I'm on my way to see an important client, and maybe there's a part of you that wants to rage at the officer, right? But then there's the poker face part of you that kicks in and says, hang on, now is not the time for that. There's the part of you that, officer, here's my license and my insurance. I hope you're having a good day. Right? And so that's part of you. And again, elders who become executive in the care, one of the things that you see is that they're not able to keep their poker faces anymore, right? I mean, they just kind of let it all go, right? So these are different things that we're doing to measure executive function. If you look at, a lot of this is based on, there's an instrument that we use, it's called an exit. It's scored from 0 to 50. The higher your number, the worse you're doing. Young adults will score 0 to 7 on this test. Healthy elderly retirees score 8 to 14. Assisted living level of care, the cut point of a fail is a 15 or higher, and assisted living levels of care will score 15 to 22. 23 to 30 would be like a nursing home level of care range. We went to a nursing home this test. And so what I can tell you is that on this executive test, I always use my kids as an example. You may have heard this before, but when my oldest daughter was 4 years old, she got a 24 on the exit. So she got a 24 on this test. So she was scoring, she got a 24 on the exit. And so when my oldest daughter was 4 years old, was she preparing her own meals? No. Was she managing her medications? Like if she got here? No. Was she managing her money? No. Was she bathing herself? When my oldest daughter was 4 years old, did she ever say, hey Dad, it's 7 o'clock, I'm going to go take a bath, I'll be down in 20 minutes? I'd have to do it all for her, right? And so, but she could be in the bathtub, right? Like she's not going to drown, right? So there's a difference between being able to be in a bathtub versus being able to bathe yourself. Just like there's a difference between having money and managing money, right? So again, it's all about the verbs. Right, so when my oldest daughter was 4 years old, she needed a nursing home level of care, right? Because she needed help with both her basic and her instrumental activities of daily living, right? So when she was 4, how was her vision? Awesome, better than mine. Yeah, how's her hearing? Her medical comorbidity burden. She doesn't have arthritis, hypertension, never had a heart attack, she didn't have asthma, she doesn't have any medical problems. Her psychomotor speed. rhythmically slow. Not like she's like super fast. How's her memory? It's like really good. 4-year-olds will smoke you in memory. Right? That's true. That's right. And so I always tell people that if memory, vision, hearing, psychomotor speed, if all these things were important, then the world would be ruled by 4-year-olds, right? Because they're better than us. They're better than us at all of that stuff, right? But the world's not ruled by 4-year-olds. How come? Because they have no judgment, they have no insight. They kind of problem solve their way out and pay back, right? So again, it's executive function, executive function, executive function. We'll do different clock drawing tasks when we're assessing this. So we're asking the person to draw a picture of a clock. This is 1:45. This is the clock test. And you can just start to see all the errors that executively impaired people will make. And so I'll go over all of it. So you can see all of the thousands of errors. Here's one, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So again, they're just not able to plan. So again, the instructions are, I want you to draw a clock that says 1:45, set the hands and numbers on the face so that a child could read it. So there's these potential intrusions embedded within the instructions. And you see this person is perseverating on face. So I'm going to kind of cruise through the stuff. And so this is my son when he was 7, right? So Kevin, when he was 7, this is his clock. It says 1:45. So Kevin, when he was 7 years old, he's 9 now, his clock says 1:45. So he scored 25 out of 30 on the mini middle. He passes the mini middle, right? I mean, he's generally oriented. He can spell most of world backwards. He remembered the 3 out of 3 items. He can draw intersecting pentagons. He passes the mini middle. But if you ask him to do a verbal fluency test with him, and so in this case I use the letter S, he gets 2 words in a minute that starts with the letter S, right? He knows words. I mean, he's reading here, right? So you can see he's executively impaired. And he's scoring an assisted living level of care range, right? In fact, Kevin needs an assisted living level of care. He doesn't need me to help him with toileting or ambulating or feeding. He can do all that, but he still needs the higher order skills. This is my daughter when she was my oldest daughter was 10. This is what she did, right? So again, she easily passes the mini middle. She's passing clocks. That's really good, right? That's pretty good. She gets 14 words in a minute that start with the letter S. Her exit is now, she's scoring at a healthy, elderly, retiree level of range. And the truth is that when my oldest daughter was 10 years old, like, if something happened to Tracy and I, my wife and I, and someone said, gosh, Megan, here's what we're going to do. We're going to have you go live at the Air Force villages. She could, right? And so it's like, if she lived in a continuing care retirement community, kind of quote unquote independent living part, where they have communal meals, where they have weekly housekeeping, where they have a laundry service, where they give you transportation to the places that you need to go, she would be fine, right? I mean, she could live in the Air Force villages. She'd fit right in. So it would make her right. So again, you can see just sort of executive function. Sometimes, kind of going back to vascular dementia, this is what you're looking at here. What you're looking at here is. So this is age. Down on the bottom you see age. So as you move to the right, the sample is getting older and older. And again, this is the exit scores here. The first group of circles is children. So you can see children hovering And you know, around the age of 10, they're hovering between, you know, about 5 and 25, right? That's where their exit scores are. And then you become a young adult, you myelinate up, and you're scoring low, low, low on the exit, which is good, good, good. And then down here, the red dots are our Air Force Village residents, actually. This is the group that lives in the towers, not independent living, but the ones that are living in the towers, right? Where they're getting the communal meals, the weekly housekeeping, that kind of thing. And then the blue circles are diabetics, right? And so you know, what is more amazing to think about? Is it more amazing to think about that, you know, diabetics have the same range of executive impairment as elders who are, you know, about 15 years older on average than them? Or is it more interesting to think that both of these groups have the same range of executive impairment as 8-year-old children? Right? So again, when people become executively impaired, they lose capacity across multiple functional domains. And you look at, kind of going back to our lady, the patient we've been talking about. So she's not depressed. She gets a 3 out of 15. Her memory is great. An 8 out of 8 is a perfect score. So her memory is good. She easily passes the memory impairment screen. 27 out of 30 on the mini-mental. That's really good, right? I mean, that's a pass. She fails the executive clock drawing task. She barely fails the copy task. And she gets the same score on the exit that my oldest daughter did when she was 4 years old, right? And the truth is, if I put a 4-year-old in a house and left him there for a year, it would probably look like that, right? It would probably look like that. If we look at what correlates with our functional status measures in our APS sample, if you look at what best predicts money management, it's always going to be the exit that we use. If you look at the ability to use the telephone, again, executive function is what's predicting functional status, even in the APS sample. For this lady, you know, you say she has mild memory impairments, which is true. She has severe executive deficits, also true. Her diagnosis is dementia. She doesn't have an Alzheimer's disease dementia, though, right? Her memory's too good, and it's too prominent for Alzheimer's disease. We state that because of the cognitive impairments, she's unable to attend to those self-care activities. And then finally, we state that her physical condition, undernourished, feces on hands and clothes, and her living environment pose an imminent threat. She doesn't have any water, any electricity, and we recommend an emergency room. That's what we recommend. And so the other question that will sometimes come up is, you know, APS will want to know is, especially with the financial exploitation cases, is how long have they been incapacitated for, right? So they may have been given money to someone for the last 2 years. So have they been incapacitated over that 2 years, or have they been? Did they only recently become incapacitated? They'll want to know how long for it. It might determine what happens to the alleged perpetrator, depending on the outcome of the case. So if it's Alzheimer's disease, it's very easy to predict. With Alzheimer's disease, the mini-mental is really good at predicting this. The cut is scored from 0 to 30. The higher your number, the better you're doing. The cut point for a fail is a 24 below. And people with Alzheimer's disease predictably lose 3 mini-mental points per year. So if someone has a mini-mental of 18, then you just say, well, 24 is the cut point for a fail. To 18, they've lost six points. If they're losing 3 points per year, that's 2 years. So then we can conservatively estimate that they've lacked capacity for 2 years. It's really easy with Alzheimer's disease. No, because we can do this retrospectively. We can do it retrospectively. We don't need baseline. If it's not Alzheimer's disease, it's harder. If it's not Alzheimer's disease, then it has to do with the severity of their other cognitive deficits. And what we're also really looking at is it's not so much their history of cognitive performance, it's their history of functional performance. And so in financial exploitation cases, you know, if we learn that starting, 2 years ago is when they stopped driving. 2 years ago is when Meals on Wheels had to start ensuring that they get safe meals. 2 years ago is when the neighbors stepped in and said, we'll help you with your grocery shopping. Then we kind of mix the cognitive performance with the functional reports, and then we estimate based on that. So I think we're really good at estimating how long someone has been impaired. We're very good within the year. I mean, very good within the year. Within 2 years, we're still really good. 3 years, we start to push it, but we're not really able to say anything beyond 3 years. And most of the work that APS does, a year is almost always sufficient. They just need to know, have they been incapacitated over the last year? That answers their question 95%. Cool, any questions before the break? Good.
Good job.
Thank you. Excellent, perfect timing. Okay, it is 12 noon. We'll resume in 1 hour and 15 minutes, so please don't forget to come back and listen to your
I'm walking too far ahead. You're calling to me. I can't hear what you said. You said to go slow. I fall behind. Second hand unwind.